Thank you very much for inviting me for this talk. I'm going to talk about sex or gender differences in multiple sclerosis. I'm going to go through sex and the immune system, the effect of hormones, the effect on neurodegeneration, and then talk a little bit clinically about menopause and talking to patients about these issues. So sex definitely has an effect on the immune system. We see this epidemiologically in that we know that the female sex is a risk factor for relapsing MS. Probably this is predominantly based with genetics. Genetics can affect the inflammation, the immune system, with female genes encoding for a stronger immune response leading to the autoimmune pathology. But we also know that sex hormones interact with those genes. And we're also finding through research that there is an increasing incidence of MS in females compared to males. The overall incidence is rising more in women than it is in men. And this might actually suggest that there are also some environmental factors. Some of these have been postulated to be things like early menarche, increasing obesity in women interacting with hormones and genes, and possibly factors like vitamin D having a different influence on the hormones and genes. So we do know that sex can affect the immune system. We can see increased T-cell expression. In female genes, we can see this predominantly on the right side of my slide, where women have an increased expression of these T-cell associated genes, predominantly in their earlier parts of life, but when individuals are a bit older, women begin to have about the same activation of these genes as men. So it's not just the genetic potential, but we know that there must be a hormonal interaction because the female to male ratio pre-puberty is exactly the same, 1:1. However, with puberty, we see the 3:1 ratio of women to men. And then for late onset MS, we again go back to women and men being equal in their incidence. So this is just my cartoon of the effect of sex hormones on people with MS, and we can see on the left is women. So women tend to have more inflammatory activity. We tend to see increased in T1 expression with more myelin-specific T responses, more robust responses. And this leads also to increased blood-brain permeability, and we see this with more relapses, more GAD-enhancing lesions, and the risk of MS being higher, the risk of relapses being higher in women. However, on the male side, we tend to see more of a shift from the Th1 to the Th2 phenotype, with decrease in myelin-specific T responses and decreased humoral responses. On the other hand, we tend to see more neurodegenerative changes in men, and this may not be the testosterone, but actually the loss of testosterone that promotes neurodegeneration with increased axonal damage, gray matter atrophy, and therefore we tend to see a more progressive phenotype in men. So the hormones can affect the clinical course in MS, and we see this predominantly in the women, where with pre-puberty, we see sort of the same number of risk of MS, risk of relapses, and really not a lot of progression. But as hormones become predominant in puberty, we tend to see, again, more relapses. And in pregnancy, because the hormone level is more estrogenic, we actually see the loss. Whereas men and women become much more similar later in life, where with menopause, we see fewer relapses, but more progression. So aging and declining sex hormones result in a relapse decline, less gadolinium, but more of a progressive course. So looking at the effect of sex on progression, the left side is females, the right side is males. We can see with the gray bars that that's inflammatory activity. We have a lot more inflammatory activity in the women than in the men. But then if we look at the green bar, we see that we have earlier and more sort of compartmentalized inflammation, more neurodegeneration earlier than the men than in the women. We have seen on MRI that women tend to get more gadolinium-enhancing lesions. There's actually no difference in the total number of T2 overall or T2 burden, but there is an increase in more active gadolinium. Whereas in the men, we've actually started to see that there's a little bit more of the compartmentalized inflammation, perhaps more in the way of pearls and more atrophy. So we think that male sex may be a risk factor for progression. Male patients develop disease later, they experience fewer relapses, they accumulate disability faster and reach EDSS milestones more rapidly. Women who develop MS after the age of 50 actually behave similar to men. However, it's really interesting that we find, in general, lower testosterone levels in up to 40% of men with MS, and this often correlates with a higher disability. So it's possibly the lower testosterone that may be driving some of this. Men tend to show poor recovery from initial exacerbations, and they have earlier cognitive impairment and more regional gray matter atrophy and spinal cord atrophy. So sex hormones may be neuroprotective. Looking at the brain aging, neurodegeneration, and sex hormones, we can see men in the blue bar, where we start to see a decline in testosterone around the age of 30, and it decreases by 1 to 2% per year. So you can see the nice slope of the testosterone decrease in the men. Testosterone tends to improve the survival of human neurons and astrocytes. It can be neuroprotective with an increase in BDNF. It may stimulate neuroplasticity. We've seen some models that show increased synaptic density and growth of neurites. And in a brain injury, we see reduced reactivity of astrocytes and microglia. So it also may promote myelination. So it's interesting that although we can see this in animal models and in some human models, we tend to see the progression in MS, and that might be because of that lower testosterone. Testosterone is actually converted to estrogen in the brain, and therefore a decline in either sex hormone would result in less stimulation of the estrogen receptors in the brain, which could account for some of this. So what about treating with testosterone? It seems like a natural. There actually has not been a lot of studies in MS patients using testosterone as a treatment. There's one small study with 10 male patients under the age of 65. In general, they did have lower testosterone, and it was a crossover design, so they were their own controls. They had measures of disability and cognition, and what we saw with the testosterone supplementation was there was an improvement in the PACET and slowing of brain atrophy. There was no significant effect on gadolinium-enhancing lesions. Other studies in general with men with MS and without MS do show some increased vitality in men who have low testosterone and are treated, and an increase in muscle mass. So when we look at the women, in the red line, we see that women tend to maintain their levels of sex hormones up until about menopause. The average age of menopause is around 51, and then you get this precipitous fall in hormones. And this is why it's such a struggle, why menopause has so many symptoms, because it is such a dramatic change and the brain is very sensitive to estrogen. So the loss of female hormones now may result in progression, and we do see that women who are postmenopausal have similar progression to men after the age of 50. Some of this may be hormonal, and some of it is just age-related in general. Some studies have noted an inflection point in worsening EDSS at menopause. Other studies have not confirmed that. There also may be confounding factors when we're looking at menopause, because it is the same time that we may see increasing BMI, age-related changes, comorbidities, etc. So sex hormones in the women tend to be neuroprotective. I think it's been long known that estrogen is neuroprotective in animal models. We see binding on the estrogen alpha receptor on T cells and astrocytes, reducing inflammation, but binding on the estrogen beta receptor on oligodendrocytes induces remyelination. Estrogen regulates apoptosis, has antioxidant effects in animal models, and results in axonal sparing and increased synapses. On the other hand, loss of estrogen in menopause has been shown to result in hippocampal and prefrontal atrophy, reduced processing speeds and cognitive and verbal memory. Menopause itself is associated in MS with increased disability, progression, cognitive decline. We can see that there is a larger interaction if women are smokers. We also see, similar to men, increasing cortical atrophy. So what about estrogen treatment in women? Estriol is probably the estrogen of choice for the brain because the brain has estrogen beta receptors, whereas estradiol does not utilize the beta receptors. In Europe, estriol is the common hormonal supplementation, and in North America, it tends to be estradiol. With supplementation, studies have shown some improvement in processing speed, reduction in cortical atrophy, and the estriol cognitive improvement was correlated with less cerebral cortex gray matter atrophy. Some studies have also showed reduced serum neurofilament light levels. But overall, all of these are small, and we need larger studies with postmenopausal women with MS. Just like women without MS, the hormone supplementation really must begin either perimenopausal or very early after menopause, because after a while, the receptors are lost. So we have to be very in tune with when women may be entering that perimenopausal, menopausal time frame. So Isabella is a 51-year-old female. She was diagnosed 18 years ago. She's had 5 or 6 relapses over her 15 years, and she was initially treated with interferon, then dimethyl fumarate. And her last relapse was 5 years ago. I felt it was a true relapse with a sensory band, some mild weakness, and increased bladder symptoms. And she had an EDSS of 4. I therefore switched her over to rituximab, and she was stable, no new lesions on the MRI for the past 4 years. She came in because she was doing poorly. She was seen because her tongue had a very burning sensation. She had marked fatigue, marked cognitive change. Her bladder seemed worse. She was getting random electric shock sensations, and she felt that the rituximab was not working. She was much, much worse with her MS. I examined her. Her exam was unchanged. We did an MRI. There were no new lesions, no GAD lesions, and this included spinal cord. However, she was adamant that she was having a relapse and needed steroids. This is a very common scenario in my practice, particularly with women in their late 40s and 50s. And so we have to go through the effect of menopause in MS and symptoms. So hormones decrease, and as I mentioned here, with estrogen, there's quite a precipitous decrease, but in perimenopause, we don't just get a decrease, we get a lot of ups and downs of the estrogen, and this causes a lot of problems perimenopausally. At the same time, progesterone to testosterone and melatonin are all decreasing. So menopause and MS have very overlapping symptoms. They do have overlapping comorbidities. A lot of things occur with sexual dysfunction, mood disorder, bladder dysfunction. And MS symptoms themselves can be exacerbated by perimenopause because of the hot flushes, the lack of sleep. So the hot flushes can give Uthoff-like pseudo-relapses. Patients feel they're worse all the time. But the clue is that they're clinically not different with their exam, and there's no MRI correlate. So you just need a degree of suspicion. Relapse activity is less common with aging, so sort of looking going into it, is this a relapse? An older person has a significantly less chance of relapse. In this case, the patient was on a highly effective therapy, also very low risk of relapse, and she had a multitude of symptoms. Generally, a relapse is fairly anatomic. We can kind of place where the lesion is, whereas pseudo-relapses, fluctuations with progression, and menopausal fluctuations tend to have multiple symptoms. Sleep is also an issue in menopausal women and aging. Sleep and mood and anxiety increase with menopause, and it negatively impacts cognitive functioning. So in general, the prevalence of sleep dysfunction in MS is high, and it's more common in women, and it's more common in menopause. So what are these symptoms? Are they MS symptoms or menopausal symptoms? Yes? Well, I can find a few that are not MS symptoms. One of them would be hair loss, other than maybe with teriflunomide. Many of my patients are convinced they're MS symptoms, but they're not. So, there are a few up here that are actually not MS symptoms in general. Generally digestive problems themselves, not MS. But look at the list. You can imagine why our patients are confused whether their changes are due to menopause or due to MS. So there's actually an increase in pain in menopausal women. Estrogen is actually good. It reduces the pain. The threshold is higher for pain. I guess we need that for childbirth and general life experience. So with menopause, pain increases. Women feel achy. Their joints ache, their muscles ache. They just ache all over. And of course, somebody with MS is going to interpret that as their MS. Paresthesias are actually common. In general, my general neurology practice, half the women I'm seeing in their late 40s and 50s for is this as MS are just perimenopausal. They have paresthesias, they migrate, they have hot patches, they have burning stabs, they have headache, they're not sleeping, they're irritable. That's not MS, that's just perimenopause. We see more headaches around perimenopause. We see more GI symptoms, diarrhea, constipation, but that's not a typical neurologic symptom, which is more continence related. And of course, we do see more depression and cognition. In women without MS, cognition does decline with menopause, so it amplifies the problems in MS. Andropause is a little harder. It's just not so well studied. We tend to seem to neglect men in MS a little bit, I think. So again, we see things that are very common with MS as well. We see diminished sexual desire, erectile dysfunction, cognitive decline. Men who are losing their testosterone do feel more fatigued and have more depression. And of course, a loss of muscle mass, bone density, and increased visceral fat. So there's an overlap with aging. With male andropause, we see worsened motor disability, fatigue, neurocognitive and psychiatric symptoms that are all kind of a combination of these two. So what about hormone supplementation? At the moment, there's not enough evidence to suggest supplementing with hormones to alter inflammation or improve neuroprotection, but I think these studies are ongoing. Men with low testosterone, you might want to suggest they consult with their doctor. It might improve their libido and help maintain muscle mass, especially a younger male. We should all go into life testing our hormone levels in our 20s so that we know what our baseline is, and then we will know when they're actually low and need to be supplemented. And maybe that's something that we'll be doing for our MS patients in the future. It's nice to know that reproductive females can use the birth control without concern, and hormone replacement therapy should be discussed around perimenopause. And often I do find that women feel better, and it really helps to send them to their family doctor to talk about that. So HRTs can be used in women with MS unless there's a high risk because of high disability for DVT. There's an issue related to the type and timing of the estrogen, but I think overall fewer menopausal symptoms benefit our patients. So we try and talk to these around these issues with women. Oftentimes women think they're having relapses when they're around their menstrual cycle, so I try and educate around this. I reassure that they're not relapses. I try and reassure women who are perimenopausal that what they're going through is not their MS relapses, and we discuss hormone therapy. So what about Isabella? Oops, I'm going to go back. Well, she complained of burning tongue, which actually isn't an MS symptom. It's a menopausal symptom. Increased fatigue and cognition. I felt that it was a combination of menopause, not sleeping. Her worst bladder, it did improve when she went on some estrogen supplementation. So again, women do have more bladder issues. The electric shocks, random electric shocks, are actually more of a menopausal symptom than an MS symptom. So she did go on to hormone replacement, and she did see improvement in a lot of these symptoms, and her anxiety levels went down. So I just highlighted a couple of these that she had that are not menopausal, or that are not MS symptoms, but are menopausal symptoms. So it's really helpful to kind of have a list of this and go through your patients. We've already heard about comorbidities, and so we have to think about these in addition. I think there's a difference in talking to men than women, and one of the issues is that men tend to have a lower health literacy. So I find it's more challenging to talk to men about diet, exercise, maintaining good health parameters. But I think as patients age and as they lose their hormones, that we have to be very careful to counsel about all of these comorbidities in addition. I thank you very much.